of mine, Dr. Pittman-Wagers. Dr. Pittman-Wagers is a psychologist who's a teaching professor and clinical psychologist in the Department of Psychology and Neuroscience at the University of Colorado in Boulder. She has a strong interest and has been involved in research looking at psychosocial experiences of SCAD patients, and she's part of the team that's actually looking at developing an app for SCAD patients and their families. And she has a particular area of expertise, which is she's actually a SCAD survivor. And today she's going to talk to us about the link between depression, anxiety, migraines, and SCAD. Dr. Pittman-Wagers. Thank you.
Hi. I was really excited when Jackie asked me to do this topic because, as you know, as a SCAD survivor, whenever you get more than a couple of us together, inevitably the question about migraines comes up. So this is a nice opportunity for me to find out more about what's going on in the field. So it's really a presentation about many areas of overlap. No disclosures to report. So what we're going to talk about in this 15 minutes is the prevalence of anxiety, depression, and migraine in the SCAD population, the potential relationships between these disorders. This is really just Tina conjecturing. The potential mechanisms, Tina conjecturing. Although there's a little bit of data. And then some unanswered questions. That's a big slide. And what can we do for patients? So if anybody needs a nap, this is kind of the gist of the talk. There's a lot of overlap. So you could just check out for the next 12 minutes and you would have really gotten the point. But let's start by establishing some baselines. So prevalence of migraines in the U.S., this is from a study based on data from the CDC in the U.S. It came out a couple of years ago. Prevalence of migraines in adults is about 14%. I just saw a study last night that said 15%, so maybe it's rising, who knows. In females, 20%, males, 9.4%. The group that gets hit the hardest with migraines is this group of women between 18 and 44. And just bear in mind that that encapsulates most women's reproductive years, right? So remember that. A few studies have come out looking at migraines in the SCAD population. So the green bar here is the data from the last study, right? And then compare that to what people are finding in terms of prevalence of migraines in the SCAD population. So 32, 40, 43%, 38%. So quite a bit higher than what you'd expect from those larger epidemiological studies. And then prevalence of anxiety disorders, 18.1% of the population in the U.S. Turns out the U.S. is really good at anxiety disorders. That's one of our superpowers. Maybe just in the last few years, I don't know. But anyway, when we compare that to global prevalence of anxiety, guess which line is female and which one is male, right? Women have a much higher prevalence of anxiety throughout the lifespan. And then prevalence of depression, about 7% of adults in the U.S., among females a little higher, among males a little bit lower, right? So again, through the lifespan, women have more depression. Congratulations. All right, and then when we look at prevalence of anxiety and depression in the SCAD population, a number of people have already mentioned that. This is no surprise at this point to y'all that anxiety and depression also high in the SCAD population compared to population norms, right? And by the way, there's so much comorbidity between anxiety and depression, and it often doesn't make a ton of sense to talk about them separately. And I'll talk about that a little bit more tomorrow as well. So I thought this was interesting. So this has nothing to do with SCAD, right? Maybe some of these people have SCAD, but there's also just a lot of comorbidity between migraines and anxiety, right? So this is a sample of folks who presented at an anxiety disorders clinic, right? And look at what percentage of those folks also had migraine. right? Again, more females than males, right? But so this isn't a migraine conference, but I think that that's pretty interesting. The other interesting thing about it is that from a treatment perspective, treatment of anxiety disorders in people who have comorbidity between anxiety and migraine often results in a decrease in migraine frequency. So what's going on here? Well, so if you look at SCAD, migraine, anxiety, depression, maybe we're talking about vasculopathy, at least in SCAD and migraine. We're certainly talking about stress. That's been mentioned in almost every talk so far. And then hormone fluctuations. So I'm going to talk about vasculopathy. No, I'm not. That's ridiculous. Why would I say I want to talk about vasculopathy? No, that's way above my pay grade. I'm not talking about that. How many people actually thought I was going to talk about that? You're kind. Okay. So let's talk about stress. Now there are many studies, some of which have been mentioned today. I only put a couple down here. But emotional stress, clearly established at this point as one of the most common precursors to SCAD. In our study that was published last year, SCAD patients were at least moderately stressed during actually the year prior to SCAD and the 2 weeks prior to SCAD. So we know that stress plays a role. Stress and migraines. So perceived stress is really regarded as the most common trigger for migraines in a bunch of studies. I've just referenced one here, but go look at the literature. It's all over the place. Stress is also the this is what I tell my students, it's like a gateway experience for anxiety and depression. So even on a molecular level, when people are stressed, that activates a corticotropin releasing factor, say that 10 times fast, which is a stress hormone, and that can lead to anxiety. Now, and then one of the consequences of that is that you increase molecular activity of serotonin receptors, and that can increase the risk of depression, right? So you see this relationship between stress, anxiety, and depression, especially for prolonged stress. So, and then what's going on in terms of hormones? Well, I teach this women's mental health class in Boulder, and I make people memorize this. So these are the hormone fluctuations that happen during the menstrual cycle, and I don't have a pointer, but the red line is estrogen, and you'll notice that at the very right-hand side, there's a drop, right, in estrogen and progesterone, which we're not even talking about, but we don't have time. So estrogen drops precipitously right before menstruation. This is called the late luteal phase of menstruation. It's also a time when a number of women may be vulnerable to increased stress levels and to, guess what, anxiety and depression. Hormone fluctuations in pregnancy are even more dramatic. At the time of delivery, right, there are these, so look at the purple and blue line. The purple is estrogen. Sorry for the resolution of this photo, but so estrogen drops off, thwomp, right, boom. And that's also a time when, as has been mentioned already, people may be more vulnerable to anxiety and depression, especially if they haven't, or even if they haven't experienced those symptoms before. And then we talk about perimenopause. Perimenopause and menopause are my favorite topics lately. So what you notice here, so the blue shaded area is the ovary reserve, the follicles, which decrease in production. But notice these lines on the right-hand side, follicle stimulating hormone increases, and estradiol and progesterone decrease really precipitously. And although the lived experience might be a little bit more like this, not such a straight, reliable line. And indeed, some of the research on depression and anxiety during perimenopause, which again may affect women who've never had depression before, does seem to have some relationship with the hormonal fluctuations, not necessarily just the mean levels of estrogen, but how much of a kind of bumpy ride down are those levels of hormones during perimenopause. Now, I just want to acknowledge that Not everyone experiences these hormone fluctuations. Some SCAD patients live in chronic but stable low estrogen states virtually their entire lives. Fortunately, they seem to tolerate this low estrogen state just fine. So, SCAD and estrogen, so this is from an article published this year. Sharon Hayes is one of the authors here. So lots of attention at this point to the idea that low estrogen states, and I would sort of put in parentheses with a question mark, maybe fluctuating estrogen states, are associated with increase in chest pain. Certainly, with postpartum SCAD, that's a time when estrogen decreases rapidly. And then also this period of time, 42 to 52, is the typical age of perimenopause, and we see what happens there with estrogen. Migraines and estrogen actually follow kind of the same pattern. So migraines in women are most likely to occur in the late luteal phase of menstruation, during perimenopause, and then again during the hormone-free stage of contraceptive use, right? And I already kind of mentioned this, it's a little bit redundant, but anxiety, depression, and estrogen. So for some women, especially, they seem to be vulnerable to developing greater symptoms of anxiety and depression during low or fluctuating estrogen states. One exciting development along, in this field is this publication 2 years ago around this gene network that does seem to be disturbed in women who have premenstrual disorder, right? So in the kind of effect of the disturbance in this gene network is that these women are more vulnerable to hormonal fluctuations in the late luteal phase of menstruation and more likely to develop a number of symptoms, including mood symptoms. We don't know exactly how this gene network might interact with other phases of women's reproductive lives, but it's an interesting question. There's a lot that we don't know, actually, about women's bodies in general. It wasn't until 5 years ago that the National Institute of Health said, oh, you actually probably should have equal numbers of female rodents, primates, and humans in studies compared to males. So we haven't had that much time to catch up. So there are limits to what we know, right? I talked really fast. I'm ahead of time. Yay. All right, so unanswered questions. These are just things that were, rattling around my head last night. Certainly the idea that correlation is not causation. We need to sort of bear that in mind. There's a lot of correlation here, but we're not totally, we certainly haven't established causation, I don't think. What other factors might connect those experiences and explain those high rates of comorbidity? Are there treatment approaches that might be informed by those relationships? What more can we learn about vasculopathy, stress, and hormones? What about the role of progesterone? Progesterone is just, it's just underrated. It isn't really deserved. And then what kind of genetic factors might affect those relationships? So, and then given that there's a whole bunch that we don't know, here are some recommendations. And I'll talk about this tomorrow too. Evidence-based treatment for anxiety and depression, and I have a couple of recommendations about that. For some patients who are having migraine, keeping a headache diary. Headache diaries are super easy to get, they're abundant on the internet, and then a referral to a neurologist who specializes in migraines would be wise. But if you've got the headache diary all filled out before you end up in your office, a lot of the work has already been done. A referral to a sleep specialist, because sleep deprivation also can trigger migraines, and there's a great CBT-based intervention called CBT-I, CBT with a little I, that's pretty effective for sleep disorders. Stress management, I'll talk about that more tomorrow. The other just sort of editorial point to make here is that often when women have unexplained symptoms, and certainly symptoms that have an emotional overlay, the explanation is far too frequently, oh, she's stressed. And that may be part of the explanation here, but I don't think that it's the whole story. I just want you to bear that in mind. Thank you.